Yes, that's very nice.
Do you need a pen? Good.
So privileged. To join us because of these silos. And that's why initially oh, are you? So nice to see you. No, I don't know what that. Wow, Jim. Yeah. Oh, did you like it? Yeah. It'll be a lot of fun. Good, I hope you.
There's a second one.
Oh, anyway, that was our experience. This is hasn't changed. It's still staring us in the face. And it works. Because when we started, we're talking about how urban health is both habitat and health. And here in the Jorge Enrique Boy, he got me into this almost 30 years ago. And bureaucracy, the international results, Well, we've got like-minded. That's fine, yeah,
hopeful moments, but then it fell apart. Sort of healthy cities was
I remember, they asked me to do this, my specialty at the time, what we call public administration. And so the layering of public administration and how that makes it difficult to deal with the urban pool. This is a teaching pediatrics professor. And he said, I quickly realized that I wasn't skilled in I was treating the same children over and over again. And there was no other policy to deal with brought that children into office. Here's an highly skilled medical professional with modern science we produce. He was handing out 2 facts.
I'm going to work closer.
Anyway, if we can get started. Well, I just want to say hello, welcome, good afternoon. I'm Joseph Tulchin, the co-director of the Comparative Urban Studies project. And through scheduling confusion, my colleague Blair Rubel finds himself in Moscow, and I have also to excuse myself after I welcome you because I have, as we say in Latin America, bien en estribo. I'm halfway myself, not to Moscow as a Latin Americanist, but to other places. Thank you very much. And I just wanted to introduce the panel. The moderator will be our Senior Program Associate, Allison Garland, who has been working off and on with me. She started as a Latin Americanist and has branched out geographically only in the last few years. Started out with me on projects similar to this well over a decade ago when we were concerned with the issues of social policy and urban social policy, particularly in Latin America and elsewhere. And as we were schmoozing here in the beginning, just saying hello to one another, some old friends, Trudy, Harpham, and I go back mainly through epistolary contact many, many years, that I began to get involved with urban health thanks to a friend of mine in Buenos Aires, unfortunately now deceased, named Jorge Enrique Ardoy, who asked me to pull together a multidisciplinary team while I was still teaching at the University of North Carolina. And we discussed how the most serious issue in health amongst the urban poor was the bureaucratic walls that did then divide, and I think I would argue, the two speakers will comment on their own, whether it still divides our approach to this development issue of health in the cities, and particularly among the urban poor. The division that exists in virtually every major bureaucracy in the world, whether it's our own national aid agencies, the Canadians, the Europeans, or the multilateral agencies like the World Bank, IDB, United Nations, between housing and habitat on the one hand and health on the other. And to bring those two together intellectually is less of a challenge than it is politically or in the development of effective public policy. So we're very pleased today to have this session for you. We're very glad that you were able to join us. And I'll turn the session and the microphone over to Allison Garland. Thank you.
Thank you. Welcome. I just wanted to thank some of the other co-sponsors here at the Wilson Center. In addition to the Comparative Urban Studies Project, this meeting was organized by the Africa Program and the Global Health Initiative of the Environmental Change and Security Project. We'd also like to thank USAID's Urban Programs team of the Office of Poverty Reduction in the Bureau of Economic Growth, Agriculture, and Trade for its support of this seminar. With their support, the Comparative Urban Studies Project is launching a year-long seminar series to look at issues of urban poverty. And our first public seminar will be held on December 15th. And there's more information about upcoming programs in the registration desk. Also, I wanted to ask you, if you're not already on our mailing list, to please leave a card or add your name to the list so you can get information about upcoming events. And finally, out in the front area, we have program evaluations that help us with our programming, and we'd appreciate it if you could take a moment after the seminar to fill one out and leave it in the tray outside. Today, as Joe said, we're here to discuss urbanization and health in the developing world. With the wave of decentralization in the 1990s, public health officials focused on local government responses and community-based approaches to local needs and realities instead of on the centralized plans and national strategies that failed to account for the urban dimension of responding to health crises. We want to examine today how local government has responded to these increased responsibilities for the provision of basic services such as sanitation, water, and health care. Urban populations are particularly vulnerable to infectious disease, making the local actors crucial players in the fight against HIV/AIDS. We want to look at the idea that HIV/AIDS is a local government issue and that local government should be at the front of the effort to prevent and treat the epidemic. As yesterday marked World AIDS Day, it's an especially appropriate time to have this discussion. And we are here today to explore how to incorporate urban health into the development agenda, and more specifically to better understand the urban dimension of HIV/AIDS and its treatment in the urban environment. We're delighted to have with us today our panelists, Trudy Harpham and Victor Barbiero, to discuss these issues. Trudy Harpham is a professor of urban development and policy at London South Bank University. She holds a doctorate in urban geography and has written extensively on urban health in the developing world, including In the Shadow of the City, Health in the Urban Poor in Developing Countries. Currently, she is conducting an intervention study in Cali, Colombia to strengthen social capital in order to reduce violence and improve the mental health of low-income youth. Until Wednesday, Victor Barbiero served as the chief of the Implementation Support Division in the Office of HIV/AIDS of the Global Bureau for Health at USAID. With over 20 years at USAID, Dr. Barbiero was director of the Population Health and Nutrition Office at USAID India, chief of the Child Survival Division in the Office of Health in the Global Bureau for Health at USAID Washington, and director of the Population Health and Nutrition Office in Ethiopia. He is also an adjunct associate professor for the Center for Global Health at George Washington University. Prior to joining USAID, Dr. Barbiero worked at the National Institutes of Health, where he conducted research on malaria and river blindness. He holds a doctorate in pathobiology and a master's of health sciences from the Bloomberg School of Hygiene and Public Health at the Johns Hopkins University. And I'd like to begin this discussion with Professor Harpham.
Thank you very much, and I'd like to thank colleagues here at the Centre for inviting me to join you. It's very good to be here. When I was invited to speak for about 20-25 minutes today on urban health in developing countries and decentralization of services, I thought, well, what I'd really like to do is reflect on my 20 years of experience of working in urban health in developing countries. I work in Latin America, Sub-Saharan Africa, and Asia, so I'd like to just briefly mention some of the cities and initiatives that I've been involved with. Necessarily, there'll be short mentions of some things, so if during the discussion period you want me to elaborate upon anything that I mentioned, please ask me to do so. The title of my talk is Urban Health, 15 Years of Perhaps Too Much Decentralization. And I'd like to acknowledge the inputs of one of my urban health PhD students, Rob Cooch, who's I'll talk a bit about his work in a moment. Before I get into the talk proper, I'd like to give you my version of a potted history of urban health policy and initiatives. So if we go back to 1978 and the Alma Ata Declaration on Primary Health Care, there was really a reaction in the early 80s when I started working on urban health, which really was criticising the fact that that declaration of primary health care, when you look at it, it was very much premised upon a rural epidemiology and a rural administrative health structure and rural demographics. So what you saw in the early 1980s was really a reaction very much led by champions in the World Health Organization, the WHO, people like Alessandro Rossi Espagne, Iraj Tabibzadeh. These people looking at primary health care in WHO were saying, hold on, we're not taking into account rapid urbanization in developing countries and the problems, the health systems, and the urban social structures that we're finding there. So we need to adapt our model a bit. Now, the WHO in the 80s, I think, really succeeded in gaining the attention of the central ministries, mainly, of course, the Ministry of Health. So in the early 80s up to the late 80s, we did see central ministries of health beginning to engage in debates about urban health. And that culminated, for example, in the World Health Assembly having the theme of urban health around 1990. So we saw a period of highly centralized debate about urban health. We then moved towards a more decentralized state of affairs, which I suppose really was typified by the healthy city movement. Some of you will be familiar with attempts at healthy city projects in cities both in the north and the south, and I was involved with some of these, both trying to provide technical support but also evaluating them. So that really brought the attention away from ministries of health down to local government. And the objective of Healthy Cities approach, as many of you know, was to really get health onto the agenda of all the relevant sectors at the city level. So this, in the 80s, we saw local government really coming to the forefront. But of course, there was this classic problem about who in local government, what sectors. We needed to engage both the health services sector and the environmental health sector. And I should state from the outset that my work involves both of those. I work equally on health services and environmental health. And I think we desperately need more people who do that. In my PhD program, I'm trying to encourage younger urban healthites, if you want, to engage with both health service debates and environmental health debates. Now, moving on from the 80s, I'll reflect a little bit on healthy city projects in a moment, but then we see even cities decentralizing further. So let's just take, for example, a city that I know somewhat is Dar es Salaam. There was a big healthy city project in Dar es Salaam in the 80s. There are now 3 municipalities in Dar es Salaam, with the city authority in Dar having relatively little power or authority or resources. So we've gone down to a even more decentralized level. And this is not yet bringing in the debate about the bottom-up movements that have worked for urban health, the role of community-based organizations and non-governmental organizations, both national NGOs and international NGOs. So that's just, I see it as a potted history of where we've gone from a very centralized approach to urban health with central ministries of health being involved down to a level of decentralization where even some central city authorities don't have much leverage on what's going on in some parts of their cities. So, the theme of my presentation is really going to be what I call looking both ways, and a plea that we have to start looking both ways. And by both ways, I mean down towards the community, getting added value from urban NGOs who have been doing good work for now decades, and I'll talk about some of those in a moment, and towards what Lipsky calls street-level bureaucrats, the deliverers of the city services at the interface with communities. I'm going to be talking about that a bit. So we need to look down towards that level, but we also need to look up towards the national level, and I would argue we need to re-engage with powerful line ministries. I think we in the urban health business, if you want, have really missed a trick in failing to get urban health issues centrally in the mindset of some of the more powerful policymakers at central line ministry levels. And from both of these levels, we need to do more at translating best practice into best policy. If you look at the writings on urban health in developing countries, there are article and book upon books, lots of them are mine, about best practice, good pilot projects, but turning that into best policy is now the challenge. So let's just, first of all, turn to this issue about policy and the frontline workers. And this comes from some work we're currently doing in Johannesburg in South Africa, and this is where one of my PhD students, Rob Cooch, comes in. We're working with environmental health practitioners in Johannesburg. Now, to me, Johannesburg, and indeed many other of the cities in South Africa, epitomise this problem of the silo approach to urban health, whereby health services, the health ministry, cannot and fails to communicate with those responsible for environmental health. So if you look at very poor, low-income communities in Joburg, and I've been going every year back to Joburg since the end of apartheid, 1994, so we've got over 10 years now. If you go back to the same communities, and here, for those of you who know Johannesburg, I'm thinking of Alex Township, some parts of Soweto, you can see improvements in some delivery of urban health services. Primary health clinics working much better, stocked up better both with kit and human resources. But when you look at the challenge of environmental health, particularly sanitation, and sanitation remains the poor cousin within environmental health. We're doing a lot of really good work on urban water supply, but I think the biggest challenge still remains in urban sanitation. Things have hardly got better. In fact, I would argue in many of the communities they've got worse because the densities have increased, and we still haven't solved the problem of urban sanitation in some of these very low-income communities. So what's happening in Johannesburg at the moment, the city authority, which is restructuring practically every 2 years, which adds to complications, there's a lot of emphasis on environmental health practitioners, a lot of resources going into increasing their number, making their curriculum more appropriate to the needs of low-income communities, and a lot of really, I think, promising work going on with regards to environmental health practitioners in Joburg, but also other places in South Africa. But what we're finding is that if you look at the urban environmental health policy in South Africa, it's not what is being implemented at street level with the communities. So we're really trying to understand the interaction of the policy, the people who deliver the policy on the street level bureaucrats, if you want, and going back to the work in the public administration of the 1980s, where Lipsky, for example, argues that the decisions of street level bureaucrats, the routines they establish and the devices they invent to cope with uncertainties and work pressures effectively become the public policies they carry out. So, what's actually happening in terms of delivery of public policy in low-income urban communities in Joburg is what the environmental health practitioners are doing. It's not what's on the paper at the city level. So we're currently exploring some of that. Now, that's in terms of local government workers. So they were environmental health practitioners employed by local government. But also we have to, in this broad spectrum of urban health, it's such a big topic, it's hard to know where to begin really. We have to look at what NGOs are doing, what the non-governmental organisations are doing. And here I mean both international NGOs and national NGOs. And again, if we look at trends in the attention paid to urban health in the last 2 decades, I can observe a flurry of interest in the international NGOs. I'm thinking here of Oxfam, UK, Save the Children, etc. in like the late 1980s, early 1990s. But urban health is kind of falling off the agenda in the last, say, 5 years. So I think we have to examine why that is, and that's one issue we can discuss, and maybe Victor will be taking this up as well. But we have to remember that there are about 50 100,000 international NGOs in this world. That's not national NGOs, that's international NGOs. That's a figure from the UN. And of course, they're mainly in urban centres. So, you know, this is a body that, I mean, hopefully many of representatives from my NGOs are here today, and we can pick this up in the discussion. You know, what is their take on urban health? What are they trying to do? And if we look at the role of NGOs in urban health, some countries are really, in a sense, I'd call this, you know, our NGOs, does it let municipalities off the hook, where we abandon attempts to deliver effective urban health through municipalities and turn to the NGOs? Is that a good or a bad thing? And I give the example here of the Asian Development Bank's urban primary health care project in Bangladesh, covering 11 cities and towns, about $90 million, and all of it is contracting out to NGOs to deliver the services. Now, I'm hoping that someone in this room knows more about this project than I do, because I'm not personally involved. I was with an American technical support outfit that bidded to provide technical support, and we lost. So I was not involved with this project. But this, to me, seems an example of one of the biggest urban health initiatives, which is using the example of letting the municipalities off the hook. Now, there may be some people in this room who can add to this perspective or differ with this perspective. So that's, if you want, the role of the NGOs played big, very big, in Bangladesh. I'd now like to briefly turn to a different scale and the role of an NGO in a small, but I think very important and promising way. And this relates to some work I've been involved with in Cali, Colombia. And just to tell you a little bit of background about this, the municipality in Cali, now again, some of you may be familiar with this, and in about the year 2000, in a very enlightened way, they said, look, the biggest problem we're faced with is violence, homicide, particularly among youth. We're not going to get anywhere. We're not getting anywhere with our medical approach. These were medics talking, by the way. We're not going to get anywhere with a medical approach to this public health problem. We need to use a social model to this problem of this acute urban public health problem. And they said, well, in the communities in our city where this homicides and youth violence is most severe, who are the trusted deliverers of service, if you want? It's our long-standing NGOs. And there's a particular health NGO called Fundaps. And we want to partner up with them to deliver certain interventions. And I can expand upon this in the discussion period if you'd like me to. But essentially, we were involved with evaluating in a before and after design this intervention by a local NGO supported by the local government municipality, which tried to strengthen social capitals, strengthen the social interactions between youth groups in a low-income community, to strengthen social capital with the objective of A, reducing violence. Well, first of all, the objective was to increase social capital. B, to reduce violence as a result of that. And C, to improve mental health. Many of you know that urban mental health is one of my key interests, so I was particularly interested in this. Now, what was the result of that project over 3 years? Just to give you the short version. It was a quasi-experimental design, so we had an intervention community and a non-intervention community. In the intervention community, social capital levels did go up. Sorry, they remained the same, whereas in the intervention community, they plummeted. This is talking about very violent, very troubled, low-income communities, which in many senses are getting worse over the last 5 years. So in the intervention community, the NGO really managed to maintain levels of social capital in an environment where otherwise they would have plummeted. There was hardly any change in various violence indicators except for attitudes towards violence, and interestingly, perpetration of domestic violence. Attitudes improved and domestic violence went down in the intervention community. There was no change in mental ill health at all, which I'll talk a bit more about mental health in a moment. But basically this was a municipality turning to an NGO which was long trusted, well resourced, and had good rapport with the community, and I think they had, quite successful results. Now, if one looks at the story of urban health in developing countries, one starts to see the same projects and initiatives mentioned time and time again over the last 2 decades. About a month ago, there was an international conference on sustainable urban development held in Geneva, and the session on health was represented by 3 NGOs. And these are NGOs who have been working in low-income urban communities for what's now nearly 20 years. And they're all quite famous. They are the Arangi Pilot Project in Karachi in Pakistan, the Pekin Environmental Health Project in Dakar, Senegal, and the Spark Project, which particularly works with homeless low-income people in Mumbai in India. Now, these 3 projects, the theme of this conference was successful innovation. It's hard to argue that they were innovating anymore because they've been going on for 20 years. But if one looks at to why these are successful, I think it's not so surprising why they've been successful. They've looked both ways. They've really engaged successfully with the communities that they work with. They've taken local adaptations to local problems. But they've looked the other way as well. They've looked particularly to the municipal agencies that they're working with. And they've got support, not always financial support, but sometimes it's even just turning a blind eye, turning an eye to what the NGOs were up to, in the case of some of the Mumbai work. But these NGOs have been very successful. And it's taken time, a lot of time. The other thing that I think made them successful, all 3 of them used maps to argue their points. Now, as an urban geographer, you'd expect me to like maps, and I do, but I think maps are incredibly powerful tools, particularly in the urban environment, to show inequalities of practically anything. I remember I was working in a project about 10 years ago in Accra in Ghana, and we were documenting intra-urban inequalities because, as I think many of you know by now, one of the problems with urban health has been trying to get disaggregated data at the city level to demonstrate the harsh inequalities that exist in terms of health problems among different populations in the urban environment. And we weren't getting very far. We documented these inequalities rather beautifully, rigorous data, etc. And we weren't getting very far in trying to influence the policymakers and practitioners. And I'm only interested in research if it can influence policymakers and practitioners. And we were invited, we used our contacts to be invited to present to the local parliamentarians, the parliamentarians for all the sub-areas of Accra. And we showed maps. And they didn't care about the words and the numbers we showed, but they wanted to see how their area was doing compared to other areas. And that it was the map that was the powerful tool in getting some attention of the policymakers there. And all of these 3 projects have really effectively used maps in their engagement, both with looking up to the municipalities, but also to communicate with their community partners. So NGOs, very important in the urban sphere in particular, going big scale in some countries, smaller scale in other countries. Now, one of the briefs for this seminar is really incorporating urban health into the broader development agenda. And as I said, I think one of the remaining challenging problems for us is how to get this issue of health service folk to talk to environmental habitat, environmental health folk, how to get those issues together. Unless we can really achieve that, we're not going to get very much further, I think. and I'll talk a bit more about that in a moment. But also, at the community level in particular, there are things going on in urban development, particularly in urban poverty reduction initiatives, which really need health added on, integrated into it. I do quite a lot of work on urban poverty, which is not dealing with health per se. The entry point is very much urban poverty. For example, and if we're thinking of rather traditional urban poverty reduction initiatives, and it might be microcredit programs, it might be community kitchens, might be setting up informal marketplaces, etc. I think we are failing to get added value from existing urban community-based poverty reduction efforts, because we're failing to talk across the sectors. I mean, you know, this call for multi-sectoral action is a rather jaded call by now, isn't it? We've heard it for the last 20 years, but I'm afraid it's still something we have to grapple with. And for example, I'm very interested in mental health, urban mental health. Plenty of data, and I can refer to some of it in the discussion period if you want, but plenty of data now to show how urban social fragmentation is related to very high levels of common mental disorders in low-income urban populations. And by that I mean depression and anxiety, and particularly among women. Prevalence of common mental disorders, typically twice the level for women compared to men. And if you look at determinants of those common mental disorders, it's the social fragmentation, it's the lack of social support, it's the huge number of negative life events that individuals in these populations are facing that are determining that high prevalence of common mental disorder. But what's the answer to that? I would argue it's not to medicalise the problem, it's not to train every primary healthcare centre a much stressed, overworked primary healthcare worker to start adding mental health to their agenda, although that would help. But I think the answer is to say, hold on, there are a load of activities already happening in low-income urban communities, which, for example, bring people together for various reasons. And here it might be, again, microcredit, might be water and sanitation projects. If we think of water projects, bringing together typically women to improve water supply, there can be extra small activities added with small amounts of training to community development workers that can enable mental health issues to be addressed through increasing social support, increasing people interacting together, giving support to each other, even just listening to each other helps. So that's one of my particular interests at the moment, is thinking not about new urban health projects, but be thinking more about adding health to, if you want, urban poverty projects. Now, we also, I think, have to be smarter. We urban health folk have to be smarter in our arguments. And in the last, about 5 years, we know that there's been a lot of good research on urban livelihoods, the nature of different forms of capital, human capital, social capital, financial capital, etc., and how shocks upon urban livelihoods affect those different resources that low-income urban families have. And I think, in a sense, when we start to use the productivity arguments, and I'm somewhat reluctant to do this, but I think we do need to use the productivity arguments using the work, the research of livelihoods frameworks quite a bit more, in particular to looking at productive roles of and reproductive roles and community roles of particularly women in the community, what those roles mean, what burdens they place on individuals, how they can be supported. I think those are some of the arguments that might get us further leverage with policymakers and practitioners. And as I said at the beginning, I think we need more engagement with central line ministries. How many of you have been speaking to senior people in ministries of health, and how much do you think they think about urban health as an issue? It's simply not there anymore, I feel. I feel it was there about 10 to 15 years ago. It was beginning to be there. Why did it fall away? How can we get it back on their agendas? Again, I think we need to be smarter in the arguments we use. We've got much more data now. 15 years ago, we were in a fairly data-poor state. We didn't have the excellent data that we have now on urban health inequalities. So we're in a stronger position, if anything, now. But I think the decentralization that we've been sucked into, for ostensibly good reasons, has actually led us away from the powerful in the central line ministries. And again, there might be some folk here who are more in the public policy arena who can comment upon this. But certainly my work with local governments, which are often very weak, those of you who work with ministries of local government, you'll know that often within the central ministry's structure, they're very weak compared to, say, the health ministry, although, of course, this differs hugely between countries. But if we turn again to the Healthy Cities failure, and I would say that the Healthy Cities initiative in developing countries, which was supported by the World Health Organization in the 1980s, really failed. And I think it failed for several reasons. One was this issue of non-cross-sectoral communication. And I think it was overambitious. I always argue for coordinated planning but independent implementation. So coordinated planning at the centre, but really because of the inevitable turf wars, the territory wars that will happen once you go away from the central level, let there be independent planning at the lower levels. And I think Healthy Cities failed in that it was over-idealistic and in that it hoped for this very high level of communication and coordinated planning at the different sectors at the city level. And we really failed to achieve that. So as I say, intersectoral action, integrated planning, but independent implementation. I think I'm almost up for time now. But so just to I think that's the last one. Just to reflect a little bit, I think decentralization, the theme of this seminar, it's very seductive. I always say, where's the evidence that decentralization is a good thing? That, I think, however, having asked that question, I, for all sorts of idealistic reasons, have been drawn to decentralization, working closer with local government and working obviously closer with communities, NGOs, both national and local. But I think in going down the line of decentralization, which urban health was so made for. If you think, okay, what's one of the differences between urban health and rural health? One of the differences is the presence of local government and municipalities. And often the difference is that you've got a plethora, a multitude of CBOs, community-based organizations, and NGOs working at the community level. So it was very natural, if you want, for urban health as an issue to go very strongly down the decentralization path. But in going so far down the path and not looking both ways, not looking behind us, back to the central ministries, I think it's been part of the problem in improving urban health in developing countries. There are all sorts of other barriers and other challenges to improving urban health in developing countries, but I haven't touched upon those because the theme of today was decentralization. So please understand, I'm not pretending there are not other barriers out there to the problem. But I hope that some of my remarks about decentralization have given us food for thought, which I can happily take up in the discussion period. So at that stage, I think I'll hand over to Victor or back to Allison.
Yeah, thank you very much, Dr. Barbiero.
Well, thanks, Trudy. That was excellent. A lot of food for thought there, and I was telling Allison before I came, before we started today, that every chance I get, I try to talk about urban health, because it's an issue that I've been interested in and concerned about over the last 15 or 20 years since I've been in USAID. It's something that I think has had these ups and downs that Trudy had mentioned, and I particularly was interested in some of the facts that you mentioned in terms of advocacy and looking at some of the data that we have now in terms of really making a stronger case for the inevitable issues that are going to be facing us over the next 20 to 25 years in the urban environment. I call this presentation the urban crucible. It's something that I thought a lot about when we had served in India recently from '99 to 2003. And truly, I think urban health, urbanization in general, is a development imperative. The world is certainly urbanizing. I mean, that's kind of one take-home message that I think everybody around the table certainly fully understands. And I like to put this slide up when I talk about urbanization, because basically the train has left the station. These are dynamics that are starting to happen. They've been happening for years and years. Elvis has left the building, call it what you want, but urbanization is upon us, and it behooves us to recognize this sort of this issue that faces us. It's truly an important health development issue as well as a general development issue. Basically today I'd just like to give some thoughts about transitions, urban demographics and trends, urban health, what I call the urban crucible, some of the opportunities and challenges, and weave in some of the themes that Trudy talked about, as well as what hopefully we can talk about in discussion in terms of linking up with other programs, looking at some aspects of HIV/AIDS activities, et cetera. But generally try to give you some background, at least from my perspective, on why this is such an imperative. And the way I was trained was to use the data that we have to make decisions and to try to inform those decision makers with clear indications of what's going on in the urban environment. Generally speaking, if you look at urban growth if you look at world population growth, a lot of it's going to be in the developing world. Most of it is going to be in the developing world. We know that. And when we talk about the developing world, we cannot ignore the urban environment. I'd like to just spend a little bit of time on transitions. I'm sure all of you have heard about this and know about this. The demographic, the epidemiologic transition, the nutrition transition, and what I think we need to acknowledge, the urban transition. But how we manage these in the future, how we use the resources that we have to do the right thing, is what's going to be key to success in the health environment. Demographic transition, as you can see, basically you're going to have a falling death rate and a falling birth rate, an initial medium-term separation of the two, which gives rise to population growth. Population growth is not going to level off for a while. So you're going to have population growth as that first slide showed, and as we know, or as you'll see, a large proportion of that population growth is going to be in urban areas. The epidemiologic transition. This is a development axiom that anyone who's going to be in the development field in the future needs to appreciate and needs to understand. There's a clear shift occurring between infectious and chronic diseases. We still have a huge unfinished agenda in maternal and child health, in water and sanitation, on the infectious disease side, but we are really seeing a shift from infectious to chronic diseases in the developing world as well. And I don't know if you can see that from the back, but basically what this slide shows, that shift exactly to heart disease, to diabetes, to injuries, traffic accidents, etc. Mental health. These are all issues that we're going to start seeing more and more, in addition to the infectious disease agenda that we have in the developing world. Nutrition. As we all know, in the United States, obesity, overweight is an issue. We're looking at between 30%, 40% of people in the States being overweight. But overseas, you're starting to see the same sort of thing in terms of overweight populations. And just the curves of some of these countries. this is Brazil, for example, okay? And you're just seeing increases in body mass indexes from the kinds of foods that people are eating. And I think it's important to understand this also has something to do with the urban environment. What are they doing? Pre-processed foods, more foods of animal origin, higher caloric foods, okay? A fall in cereal and fiber intake. Sugar, a huge issue in terms of intake. Processed foods therein. Alcohol in places like Russia. All this relates to the urban environment. And I think when we think about this, we have to think about where are these things happening, where are these transitions occurring, and how are we going to manage it. The urban transition looks similar to the epidemiologic transition, where we're starting to see a cross. We're starting to see a cross in urban populations and rural populations. Sorry about that, Trudy. And looking at it, you're looking at almost 60% of the world becoming urban in the next 30 years or so. That's an astounding figure. 60% of the world being urban. How we manage that, how we plan from a development context, how we look at decentralization, service delivery, things like that, are going to be huge issues that we in the development community will have to face. This basically just shows that slide again. But if you look at it, if you look at it, the curve, the slope of that increase is very high in the developing world. So not only do we have an urbanizing world, but we have a higher slope of urbanization in the developing world. To me, these kinds of figures are so evident, it behooves us to make a paradigm shift almost in terms of how we deal with international development and health development in the future. And this is the kind of thing that Trudy was talking about in terms of convincing the decision makers, show the map, explain what's going on, and say these are the sorts of things that you're going to have to deal with now, because you're certainly going to have to deal with it in the future, and it's going to be much more difficult because it's going to be much more severe in the future. From a regional standpoint, again, these are the kinds of data that just give me room to pause when I start thinking about urbanization and urban health. Where's your major growth going to be? In Asia and Africa, in terms of proportion. That's not to say Latin America isn't urbanizing or urbanized, but two gigantic land masses with huge numbers of people are going to have the highest rates of urban growth. How do we deal with this? How do we begin to program differently? How do we look at the epidemiologic, demographic, and nutrition transitions relative to these issues are what we really need to talk about in the coming years. This slide just shows that within that growth, okay, you're looking at middle and low income countries growing the most. And within the urban environment, those middle and low income populations. So not only do we have the regional, the global shift, the regional shift, we even have an economic shift in terms of cities growing. And who's growing in those cities? The middle and lower income populations. A whole set of issues relative to education, services, governance, etc. So when we talk about decentralization, we talk about management of these issues, we talk about municipalities and NGOs, how are they going to deal with those lower income populations that are growing sometimes exponentially? Just to put it in realistic terms, from 1950 to 2000, if you're looking at urban growth rates of about 3.71%, that's a doubling time of about 19 years. Today, it's slowed a little bit, but we still have a doubling time of 30 years. So when you start looking at some of these cities or these agglomerations that I'll show you in a minute, you're looking at a 30-year horizon for doubling populations. Doubling. Infrastructure, water, housing, all of those sorts of things are going to double. These are gigantic issues that we face. how we cope with them, where the resources are going to be, both from the outside, from the donor community, as well as from the countries themselves, are going to be huge, huge problems. This slide shows that where's that major growth going to be? In smaller cities, less than 1 million, less than 5 million. But it's still huge. India has 600,000 villages, okay? But 5,000 major cities. And over the last 4 decades, that population has tripled to 278 million, about 28% urban in India. And it's going to keep growing in terms of percentages. So our smaller cities are going to grow. They're going to increase at a higher rate than the natural rate of increase. The doubling times are going to decrease. And it's an inevitable train coming down the track. Agglomeration. I thought this was an interesting issue when we talk about it. It's kind of like the megacities, megalopolises that we're seeing. This slide basically shows some of the major cities, the agglomeration cities that we have, and the percentages are basically growth rates. Okay? Rule of thumb, if you got a 3% growth rate, it's about a 21, 22-year doubling time. Bombay, Mumbai, 26 million. Greater Mumbai is 26 million with a 2.4% growth rate. Lagos in Nigeria, Greater Lagos, 23 million and counting. 3.6%, that's an 18-year, 19-year, 20-year doubling time. Brazil, Pakistan, Mexico City, all of these cities, these are just growing megalopolises, and how we begin to deal with the issues with these areas, these urban areas, is going to affect national development for a very long time to come. If you look at just in terms of city limits, you can clearly see the developing countryside of the equation, the middle and low income countries. China, India, Pakistan, Brazil, the kinds of countries that we're dealing with here, and the city limits. Delhi, when we were there, was well, it says here, Delhi has 10.9. The quotation in Delhi was 12 million, with Mumbai at 18 million in terms of city limits. These are huge, huge cities. In Africa, you can see it right there, those cities starting to urbanize and the services that we need. Again, this just shows the doubling time figures of Asia and Africa, which are key. Africa doubling in 22 years in terms of the urban population. Where are the services? Where's the policies? How are we going to deal with this in terms of our own approaches to development and the host governments, the African government's approaches to development? I put this up because when I used to, we have an HIV, USAID still has an HIV/AIDS project in Mumbai, in Maharashtra state. And every time I would fly in, we would fly into Mumbai, and I can remember the plane coming down. The plane would come down, and for about 25 seconds, all I would see would be that picture there, just going over shanty towns and tin roof buildings. I'm looking down, and I would say, how are we going to deal with these sorts of areas? Areas that have TV antennas, but very little else. And the number of people, a city of 18 million, so they say, with 40 to 50% of them living in these shanty towns and urban slums, where services are barely available, where most women don't even know what HIV/AIDS is, where antenatal care and reproductive health services are virtually non-existent. I mean, these are real problems that are hitting us square in the face. 3 miles away from that, you have the center of the Indian business community, where some of the richest people in the world probably live, and certainly some of the most powerful people in the world live. And it's growing. It's growing at 3 to 6% from natural rates of increase in in-migration. But USAID, the donor community, we kind of know about it, but we're not programming for it as much as we should be. And this is the kind of things that we really need to address. I put this up. This is a slide on just some of the urban statistics for India. 20% urban population out of school, 10% don't have electricity. But the points that I want to bring out here are, what are the key challenges in the urban environment? education, power, water, sanitation, fuel, shelter, health. And I put this last one in, governance. These are the kinds of things that I've devoted my life to working at USAID, and most of my colleagues have as well. How do we get at them? They're going to be magnified in the urban environment in the future. And it's not going to be easy to get at these sorts of issues. As Trudy said, sanitation, a key issue. Influences diarrheal disease right off the bat. Again, the stats. I always show this slide as well because it's quintile data, and basically what it shows, because everybody thinks the people in rural areas are worse off than the people in urban areas, and that's really not the case. If you look at the rural poor, infant mortality rates are actually higher in this study than they were in rural areas. And in the second quintile, the fourth quintile I should say, they're comparable. Of course, when you get to the higher population SES status, socioeconomic status, you begin to see better projections in the urban environment. But the point is, the urban poor are in terrible straits. Illness, same sort of thing. Respiratory disease, you're looking at comparable rates in terms of fevers from rural and urban areas of India. We're looking at similar rates, and as well as diarrheal disease. Again, it gets back to the sanitation issue, gets back to the, believe it or not, access to services issue. So these are clear indications that something's going wrong in the urban environment. It's not just a rural issue, yet we're still having trouble recognizing it. In terms of coverage, this slide basically just shows child health services, BCG, basically immunizations here, BCG, DPT3, OPV, and measles, okay? All immunization coverage, urban slums versus rural areas. I don't think you can see a clearer distinction in terms of service delivery. I mean, it's so clear the differences in these levels of coverage in the urban poor environment. Kids are dying. Polio is hunkering down in urban areas. It's like polio heaven, where you have poor sanitation and high transmission rates. And it's a deal breaker. And that's really, I think, what Trudy was saying, and what I firmly believe. It's a deal breaker when we start talking about the interventions that we want, that the urban environment will be there. The infectious and chronic disease shift will be there, and we're going to have to deal with it sooner or later. You're not going to eradicate polio until you deal with polio in the urban environment. And eventually people will see that, but it's going to take time, I fear. Again, just another issue of antenatal care. This just shows, again, urban versus rural levels, average rural levels, okay? And you can see that they're fairly comparable across the board relative to folic acid consumption, tetanus immunization, and antenatal visits. But again, it just gets back to the point of the whole idea of kind of a mask of better services in urban areas. That's not the case. Poverty is increasing. It's increasing in the urban areas faster than it is in the rural areas. I want to talk a little bit about this idea of the crucible effect. A crucible is a we used to use it in chemistry. It's a vessel where you heat things up and you can change what's going on molecularly through heat. Okay? It can also be a place and time or situation characterized by a confluence of powerful intellectual, social, economic, or political forces. I thought that was an interesting quote that I found on the internet for crucible. It kind of gets what I'm talking about when I talk about the urban crucible. What do we have? We have this confluence of different health problems all in one place. All in one place. Everything from indoor air pollution to environmental pollution, sanitation, gun violence, the kind of safety issues that occur in the urban environment, your infectious diseases, diarrhea, malaria, ARI, dengue, tuberculosis, HIV/AIDS, polio, avian influenza. If people don't see avian influenza as an urban issue, I don't know how clear it can be. I mean, this is where it's going to start. This is where the outbreaks are going to happen. And then you have at the lower level your chronic diseases. I should have put actually mental illness on this as well. You have your chronic disease, and it's kind of It's hard to explain, but it's kind of this revolving interface between chronic and infectious diseases, environmental, and infectious as well. The whole idea and social issues, all these issues coming together in the urban environment, which may or may not help us to address some of these issues. So what do we see? We know they're going to grow. We know the slums particularly will be a crucible for a lot of the infectious agents that I just talked about, as well as eventually the chronic disease elements. I talked about polio hunkering down. Water and sanitation loom. There's going to be wars fought over water, and the urban environment, again, is where it's probably going to start. Social and behavioral norms, they may facilitate or they may impede action in terms of cultural issues, in terms of access to care, in terms of perceptions. The same with infrastructure. There are certain infrastructural advantages that we can explore in the urban environment, the municipalities, the decentralized effects, so to speak, in terms of decision making, and also that local municipality. And I think Trudy has alluded to it very well. The private sector, we cannot forget the private sector and this, what USAID at least and others call the public-private sector partnership, how we can maximize that in the urban environment to really deliver the services. So there is light at the end of the tunnel. In terms of opportunities, there are resources out there. There are huge programs going on in HIV/AIDS, in infectious diseases. Malaria is coming down the pike. Still maternal and child health is coming up. Okay? So there are resources out there. It's a question of how can you begin to access those to address the problems that we're facing in the urban environment. We're lucky because even though it's growing, it's still a concentrated environment. It's still a concentrated environment. Perhaps because of communication, radio, even TV to some extent. 40% of polio messages in India, for example, were accessed through television. Mass media communication might be easier in the urban environment. And people in urban environments may be more receptive because they can see the problems right in front of them much more closely. Access to fixed facilities, hospitals, secondary, primary care facilities, pharmacies, things like that. Women don't have to walk 2 days to get to a clinic. Women don't have to walk a day to get their kid immunized. Might be easier to deliver services, but yet we still see problems in terms of general immunization in the urban areas. There's a burgeoning interest, but we still need a sharper focus, and I think that's what Trudy's message was talking about. And we do have this, I think, a very robust potential in terms of the public-private sector side of the equation. It's not without challenges, and maybe we can talk a little bit about this because I'm not quite sure how we're going to deal with all of these as well. There's great diversity in all different respects in the urban environment. The stakeholders or partners are very complex. You have the Department of Health, you have the central government, you have the state government, you have municipalities, you have urban development authorities, you have your NGO community, public-private providers, corporate interests, charities. All of those things have to come together to address these issues in the urban environment. How you manage that, I struggled with it when I was in India. We're trying to make progress, but it's still a huge, huge problem. How do we engage the municipalities and the state and provincial administrations, and I would add the NGO community and the donor community, to work together on common objectives? The kinds of things we've just seen, how do we begin to prioritize them, to put them on the screen? And how do we do it as donors as well? That's something that I think we need to deal with here. And we need to bring it to the attention of national decision makers as well. Clear messages. That transition is inevitable. Virtually all of the growth we're going to see is going to be in the urban environment in the future and fastest in the slum community. The small cities, medium-sized cities are where you're going to see all that growth. Those mega cities are going to continue to grow. And the health risks of the urban population are the same or worse in some cases as the rural population. These are givens. The data show it. How do we make it mainstream? How do we expand attention and investment to this area? There's got to be a rational global strategy that the donors keep pushing. It's not the disease du jour. It's not avian influenza or HIV/AIDS or malaria. It's all of them. And when we acknowledge that, when people begin to see that those urban systems are so weak that these diseases are not going to be addressed appropriately until we pay attention to that, that's when decisions are going to be made. One point that I guess gets more to the theme of what we wanted to talk about a little bit more here is how do you begin to program this? And my job over 20 years was to program resources. And a lot of times right isn't might. You can say something, but your bosses will say, well, we don't have any money for it. Or, nah, that's not the policy of the agency. So you have to figure out how to do it. And the way you do these sorts of things is what, for lack of a better word, what we call wraparound programs. So if you have an HIV/AIDS activity, or you have a malaria activity, or you have a maternal and child health activity, there are ways to link up your activities in the urban environment. And you try to promote urban health within a certain account or in a certain program area. We did it in India in terms of child survival. And we looked at key child survival issues in the urban environment and began to model that out and see how can you really do it. And I think in the future, that's where we're going to go with a lot of these. HIV/AIDS, it's starting in the urban environment. The stuff the president was talking about yesterday, the wonderful, wonderful interventions that PEPFAR has made, very important. They're anchored in the urban environment starting, fixed-base facilities treatment and prevention. And that's important. It's going to branch out eventually, but how do we link up more urban health to some of those very important and practical interventions? Mainstreaming. I don't know how to do this, but I'd like to hear some of the group's thoughts on this. How do you begin to mainstream urban issues beyond these data, which I feel are so compelling, but I think I'm preaching to the converted here. How do we mainstream it in our own agency programming? I think that's a challenge that we need to really look at. As Trudy said, you have to go down to the decentralized level and get those decision makers on the ground to be engaged in this and to understand that something can be done, and have them commit time and resources to it. And over time, we have to support and nurture sustained public-private sector investments. Identify those most at-risk populations. More data, more compelling information is important. Look at demonstration activities, but not small ones. Demonstration activities that run $10 million a year or so you can really see an impact at a scale level. And you can begin to see changes in trends, child maternal health, avoidance of specific diseases, improved sanitation, etc. Look at that long-term urban planning commitment. And then choose someplace geographically where these issues are key and go after them. So in terms of concluding, let's recognize that there is this urban imperative and try to mainstream it somehow. Recognize those transitions and deal with them in the urban setting. Begin to balance. It's coming. The chronic disease dynamic is coming. How do we begin to balance our own programming in terms of chronic and infectious diseases? And there are priorities in both. How do we maximize viable linkages, that wraparound idea, with other key programs that exist today? And engage the private sector more. And get those demonstration projects going. And last but not least, we have to continue to embrace this vision. Because it is a vision. It's not mainstreamed yet. And once we move forward and implement that vision, then we'll be able to make progress in the urban environment. And I'll close with that. Thank you.
Thank you both very much. What I'd like to do now is open up the floor to some questions and have some discussion. Sure, right over here. And if you could state your name and your organization. Sure, yeah.
Yeah, I'll do it too. I'm a foreign correspondent. When you mentioned Accra, Ms. Harpham, when you mentioned Accra, it brought some chills over me because I was in Accra exactly a year ago, and I took a walk into the city and drove around, and I went to some of the areas you mentioned. And I also concluded that the local Accra Municipal Authority is overwhelmed by the magnitude of filth, for example. And it has been my conclusion that the central government ought to take over the public health care, the public health sector of the whole country, not just Accra, because I've been told the conditions in the second city of Kumasi are even worse than in Accra. And everything you said about urbanization is happening in Accra at a very dangerous level, including violence and lawlessness. So, as we sit here, am I correct in suggesting that maybe in the final analysis, it is the economy, the capacity of the economy itself of Ghana and all the other poor countries in Asia and Africa, that developing the national economy, the capacity of the national economy is actually what needs to be focused on? And I also want to ask you to comment on why is it that not only in the developing world, but even in the developed world, there seems to be some kind of differentiation between the Ministry of Health and public health. I don't understand. I asked a question. I asked the Minister of Health in Ghana when he was here about 4 years ago to a question about public health. He directed me to ask the Minister of Works about that question. And I don't know how we can deal with that.
Shall I respond? Thank you for that. Lots of interesting issues. One of this first issue is what to do when local government is so weak. Should it be superseded by the central ministry? I was doing some work in Lusaka in Zambia in the late 1980s, early 1990s. And this was an urban health project funded by the then Overseas Development Administration of the UK, what is now the Department for International Development, DFID. And we were working with the local government, but it was in the middle of this 5-year project. It was regarded as so weak, the provision of health services was superseded, that their powers were taken away by and reverted to central government. But, is this the answer? I haven't got an answer. I mean, obviously, in the long term, no, because we need to strengthen the local government, the municipalities, to deliver their mandate. But in some extreme cases, and in several countries this has happened, the central ministries have stepped in. It happened in some cities in India as well, in the 1980s. So this issue is crucial. Now, you asked the question, is the answer economic growth? And we know that cities are the economic engines of countries. And you asked the question, is promoting the national economy the answer? Well, I would argue that the answer to all the urban health problems is poverty reduction. Let me state that here and now. But we know that national economic growth does not necessarily influence poverty reduction. We've long known that the trickle-down effect does not always work. I know there's a lot of debate still about the data on this. But I would argue that national growth alone, i.e. increase in GDP, is not going to be the answer to urban poverty and therefore the problems of urban health in low-income communities. We need specially targeted poverty reduction initiatives at low-income urban communities, because I don't think just national economic growth will do the job. And then this whole debate about ministries of health and public health. For so long it's always been the case, I think, that public health has been the poor relation in health. And why is this? Well, we can debate this, but often the powerful jobs in medicine and health are not related to health promotion, environmental health at all. They're to do with usually what goes on in hospitals in cities. You know, forget what happens outside the walls of hospitals in cities. The powerful health and medical people usually concentrate themselves within the walls of hospitals. So until we start changing the basic curriculum of medicine and public health at the training level, I don't think we can get away from this. And I think it is shifting a little bit, not very fast at all, and I think it comes down to the very first days that people are exposed to training, and it comes down to curriculum changes. But the powerful and elite are not very disposed to change the curriculum at the moment. But again, I think we as public health people, I'm a social scientist, but I regard myself as a public health person as well, we need to argue how important public health is in development. And that gives it, and again, it's my call to argue the productivity arguments. We are the ones who probably have more influence on national productivity, economic productivity. Public health has more influence on national productivity than medicine does. So why not give public health more power in terms of curriculum, resources, etc.? So we have to argue a different argument. We have to borrow the argument from different spheres. And using the crucible example, which I love, we have to, you turn up the heat on a crucible to produce new interactions between the molecules. I think we have to turn up the heat to produce some new interactions, sticking to Vic's analogy there.
Let's go over here.
My name is Ahmed Mo, and I'm from Howard University. I was a classmate of my dear friend here. I think we have a pendulum situation here. I was in the Ministry of Health of Ethiopia, and I can tell you they took the public out of health. It used to be Ministry of Public Health, now it's Ministry of Health. That's to answer the question. I think when the physicians took over, they start redefining public health in terms of hospitals. But the issue I am having, the pendulum comes from cities have been the parasites. They took most of the budgets. I remember when I was a director, of the 46 million at that time, 27 million goes to big cities. So I am the generation of Alma-Ata, where there is equity and justice. Now, through civil wars, disintegration of authority in the rural areas, and lack of all the services, now the cities became the magnet. So they are bringing the same poor, but they are changing their address. They are from the back burner to the front burner. But in any case, I think it is really the issue. I think totally is it's more than we can think, because the pendulum from centralization to decentralization will occur, whether we want or not. Some countries like Ethiopia, they decided to have federalism. They used to have central government, but their behavior is still central. The behavior hasn't changed. It's reorganization. They say old wines in new bottles, but the problem is the same. So I think it's a pendulum, and I'm not in sympathy with the situation that we should really reorder our social services, our economic development, and change the direction to the cities. I'm still an Alma-Ata person, and I don't know what you think. It's a debate that you and I can debate here the whole day, but I don't think the cities should get that favor at all.
Can I just say one thing? It wasn't the cities that were the parasites, it was the hospitals that were the parasites. Which happened to be in the cities. It was tertiary care that was the parasite.
And also, I don't think either of us are saying an either-or situation, because there's still a huge unfinished agenda in the rural areas as well. And you're even starting to see shifts to chronic disease in the rural areas in some respects. But I think what we were saying, that because of this in-migration that you mentioned, that there is in the future going to be a real dilemma of health in urban areas beyond the hospital side, beyond the tertiary treatment side. and really in terms of basic care and prevention. So it's not either or, but how do we try to begin to do more than we're doing now to avoid having to do too much more or so much more in the future.
Question over here. Yeah.
My name is Valeria Georgiou. I'm actually at the EPA. I'm currently a Vermont Law School student just for the semester at the EPA with the tribal program. And I want to piggyback on what he said about the influx of rural populations into cities and challenge the acceptance that urban centers will continue to grow. Because I think that if it's such a horrible place to live, why should we continue to allow this problem? And why do besides the attraction to better health services in cities, why do rural people go to urban areas? It's also because of huge development projects, dam projects that feed water to the big cities as they're increasing, that then displace indigenous people. It's multinational companies that come in and take water from the countryside to sell in markets abroad. So so that access to water is reduced and people have to flee to cities, and they go to the shanty towns and they try to continue their lifestyles and the skills that they have in these shanty towns. In India, I worked in India last summer and I saw people grilling corn on the side, probably indigenous people recently new to the city, trying to survive with their basic skills. And also because of clear cutting for exporting these cash crops to Western markets. And I think a large part of the problem is overconsumption of cities and overconsumption of the developed world that undercuts the ability of indigenous communities to live in rural areas, forcing them to flee to these urban areas. And if we're going to think of urban health, then we might need to take a social angle, like you say, an environmental health angle, attempt to protect these cultural ways of life, these environmental ways of life that preserve the environment, and attempt to keep these communities, develop micro-cities to prevent these huge megalopolises. You know, have a local but centralized center so that people stay within micro-cities, able to live some way of indigenous community life, and which honors and respects their communities, their families. They can stay together instead of fleeing, and also can provide city advantages that they also desire. So I think that we do need to branch out into other fields and connect them a little better. So, thank you.
There's a question over here. We'll take a couple together.
Hi. My name is Lisa Colson. I'm with the Population Reference Bureau, and I have a question for Trudy. I was wondering, in your examples, I agree with your concerns regarding decentralization, but do you have examples of where decentralization has worked and how?
Take a couple more. There were some questions in the back over there.
My name is Veronica Kete.
I have a parking problem, sorry.
Yeah, I want to talk about attitudes of those in the less developed world. It's no good for us sitting here in America and talking about the concerns of my country in Africa when I am in Africa and I have no concern about it. So there should be a real education process to re-educate the people, especially the women in my country. They know nothing about HIV/AIDS. They accept violence from their husbands as tradition, is a culture. There are lots of things that we need to educate these people about. And starting from where I'm coming from, starting with educating the rural population. How come you see an 80-year-old woman with HIV/AIDS? Because somebody had gone to town, got the AIDS, came back and said, oh, I've been poisoned, I've been bewitched, comes back and the old mother at home is taking care of this child so intimately and not knowing that it's HIV/AIDS. And before the child dies, she too is contaminated. So I definitely think in Africa, we need a lot of education. We need to reorient the people, especially the women who are so vulnerable to be able to stand up for what they want, to be able to say no to a polygamous man, to be able to say, no, I'm not going to get married at the age of 12, to be able to say, no, I want to be on my own. So in a case like Africa, where we are like not educated in the things we are talking about here, we need projects to re-educate the women. We need projects to let the women and children see and beyond their noses. Because I always say here, and you carry these big lofty projects to Africa, and it gets into the municipality, it gets into the government, or somebody in my country sits on it. Why is it going to this side instead of this side? And then the project doesn't work, or the project is so frustrated. Working with NGOs is a wonderful idea in Africa, because you keep away those people, those bottlenecks, administrative bottlenecks, you keep them aside and you work for the interest of, look, focus. I'm focused that I want the women. I grew up in a very subjective area. My father was a brute. So I grew up knowing how a woman can be oppressed. So if I want, when I was home, I educate women on, don't be oppressed, own property. Get a divorce if you want. Get the number of children you want. You shouldn't be controlled by your husband, So we need education. We need projects to re-educate our people in Africa.
Yeah, I'd just like to add to that. I think one of the ways to empower local governments and the response is to these types of education programs where you increase the number of stakeholders in these projects and build support within the municipalities for that kind of work. And if you want to...
Well, I just want to make a comment that one of the things that the President's plan, emergency plan for AIDS relief, is trying to do is really to try to look at gender equity in terms of the treatment that's going on, because people were afraid that just the men would have access because they were the ones that are empowered, and I think they're making fairly good success. The last statistic that I remember was it looked pretty good at about 50-50 in terms of men and women having access to treatment. So that's the kind of thing from a policy standpoint that I think we need to also move forward on, in addition to the education and getting the real empowerment for women in the African context.
Did you want to take that question on decentralization?
Yeah, examples of good examples of decentralization. I think some of it depends what one means, but I suppose this seminar should have started off by defining what we mean by decentralization, but that would probably be another seminar. I think some of the examples of the NGO projects that I mentioned are good examples, but if we take decentralization to purely mean within local government and within a city staying in the government apparatus, I think a fairly good example is the Lusaka Urban Health Project in Zambia. It had its problems. It ran from about 1985 to a bit later than that, for about 6 years at the end of the 1980s, early 1990s, funded by partly by Irish aid and partly by the UK aid. And the idea here was basically the central hospital. Here we come to the bugbear of the hospitals again, but the hospitals, everyone was bypassing the primary healthcare centres in Lusaka for outpatient visits, piling into the outpatient department of the main hospital, common in most cities, most developing country cities, where there's no referral system, essentially. You can go straight to the outpatient department of the hospital. And the idea here was, in Lusaka, was to strengthen the whole referral system and to decentralize the system by strengthening the primary healthcare centres in the peri-urban areas. The peri-urban areas are the very poor areas in Lusaka. So about 10 of the primary healthcare centres in the peri-urban areas of Lusaka were strengthened both by a lot of human resource training, but also physically enhanced, including giving them some inpatient facilities. So, for example, they'd have about 5 beds, so there was a limited inpatient facility. And by really restricting the referral system at the hospital level, people were bounced basically back out of the hospital to the primary health centres in the peri-urban areas. Now, there were problems. Again, the vested interest in the hospital was not always keen on this project. It had huge amounts of aid, international aid, so that helped. But the infrastructure, the physical infrastructure, improved enormously, including, importantly, water and sanitation. People tend to forget about water and sanitation facilities at primary healthcare centres. Incredibly important if you think for how many hours people, particularly mothers with young children, are queuing at primary healthcare centres. So just basic things like improving water and sanitation at the primary health centres, providing some limited inpatient facilities, and really getting a grip on the whole referral system in the city. I think that was a fairly successful example of a decentralisation.
Hi, John Barrazzo, USAID, Bureau for Global Health. We seem to be thinking there's a real advocacy gap, and yet it strikes me that urban and the urban issues more generally, and the issues of urban health in particular, are not going to go away. They're actually going to become increasingly on the screen of most policymakers, because they're going to be saying, well, we've made commitments to meet certain kinds of goals like the Millennium Development Goals, and we're not going to get there as our urbanization rates keep increasing. And so given that urban centers, they've been mentioned already as engines of economic growth, but they're also centers for political strife. There's lots of reasons why urban centers, and the urban poor in particular, will, I think, continue to get more attention. So the role that we play in terms of anything we can facilitate seems to be able to use the kinds of data that Vic presented and some of those targeted advocacy efforts to assist people in urban areas to make those cases for themselves. Now, but the problem, and the one I think about a fair bit, is that we talk a lot about the large cities of the world, but the fact is most of these urban dwellers are not in the big megalopolises of the world. I mean, they're in smaller cities. They're in cities of maybe 50,000 or 100,000. And those are the places where, in this context of decentralization, the capacity of local government to provide any kind of services or support is particularly a challenge. So how do we actually try to get at that problem of the secondary cities, given that, I don't agree that that the role of the central government is to try to deliver services in urban centers. I think that they typically will do it in a way that's not going to be very efficient or effective, and the complexities of the urban environment, the social complexities, the economic complexities, and just the way in which services are delivered will really make it so that the central government is not necessarily the best provider. So that's not a model that can work. So what's going to be the model for those smaller cities? We talked a little bit, you both used the word project, and it's not the conventional project that we would use, say, for working through NGOs or through a central ministry for rural services. It's a different kind of project. It's a project that brings together stakeholders in a creative way. It may actually be a project that focuses on governance issues and land tenure issues. I mean, you go to an urban slum, and the places where land tenure is more secure, households have made investments in improving their environment. It's been very critical. So you look at those, and maybe that's the project that you have to focus on. Finally, let's see here, this issue of economic growth. I had the opportunity to spend 3 weeks on a personal trip in China this summer. I hadn't been there for about 10 years. And you can't really escape the fact that economic growth in China of 8 to 10% a year has completely transformed the urban landscape in most cities in China. Now, they're still amongst, in terms of certain kinds of issues like air pollution, they're still amongst the most polluted cities in the world. But in terms of delivery of basic services, improvement in housing stock, the transformation has been quite remarkable. So I think that there are things we need to focus on in terms of how do we improve health status absent economic growth. And that's going to be the situation, for example, in sub-Saharan Africa probably for a long time. But the fact is, in places where there is substantial economic growth, how do we take advantage of it? And probably that's a good question for India, because India is poised on is on the brink of some very rapid expansion in terms of its economic growth. Okay, thanks.
John, Mike, could you comment a little bit to address Lisa's issue and build on what Trudy said about Endor and some of the stuff we were doing in India and that process?
Well, the interesting thing is you mentioned, actually even said, well, just a speculative dollar figure for, what would a demonstration project be, say $10 million a year. Well, the fact is, any project we can envision in a place like India or probably anywhere is going to be inadequate to the scale of the problems that need to be addressed. So the approach that USAID has taken, it started when Vic was in charge of the health program there, was to really look at ways in which you influence both municipalities and the central government to actually stimulate their investment of resources. And the first model that was used in Indore was to really work through the NGOs and use NGOs to connect to community-based organizations, to connect people to service delivery. And that has been successful but very resource intensive, and it's not a sustainable model. So that has evolved towards working with municipalities to really try to set up methods of coordinating services across the wards, which is the lowest level of political administration in the city, and to try to work with the municipality to coordinate the way they would provide services at that lowest level of administrative level within the municipality. And the way that's worked is really to focus on that as a demonstration and then connect it back to the kinds of support the central government provides to both the state level and the municipal level. And so, the role that we as external actors play is largely a facilitative one. It's one to try to say, well, here are some things that work. Here are some things to try to focus on as an approach. And I think those kinds of creative projects that bring together actors at the municipal level in new ways is really the kind of role that we can help stimulate. I might also add that USAID has recognized the importance of urban health, in part because of the work that's been taken on at the country level in India. And we're in the process of hiring an advisor straddling our urban programs office, our urban programs team within the Economic Growth Office and the Global Health Bureau to actually focus on urban health and look at the ways in which we can stimulate some creative approaches at country level, given that we're not going to have urban health projects, but how do you successfully address the urban health dimension, of all the different kinds of things we're doing, because the problems really are not that different as public health problems. It's the same public health problems whether you're in, it's pneumonia and diarrhea amongst kids. It's going to be, HIV, AIDS, TB. The set of problems is not a new set of problems, but the programmatic strategies have to be more creative.
Yeah, just a few things. It's that programmatic strategy. I think we need to articulate more. I mean, what I'd call them is policy briefs. We have to almost stop talking about urban health projects. Vic called it wraparound. I called it getting added value from existing urban development projects or urban poverty reduction programs. But what I think we're failing to do is articulate the policy to facilitate the production of what I'd call policy briefs, which, for example, let's take the small cities. I think there's already quite a lot of linking up of partnerships through nothing to do with health. Small cities are linking up with other small cities, and there are various facilitating actors to do that, like ICLEI, etc. But they're not currently thinking much about health. So it's really pulling out, articulating those, policy priorities. What do you do? And, first, in a particular context, it's not a global solution. It has to be context specific, of course. But, for example, the tenure issue, I'm often asked the question, if I had to do, what's the first thing I'd do to improve urban health? Provide security of tenure, preferably to the women, so it's not sold on, to generate income for alcohol abuse. So there's I think, again, we've come to a transition. Vic was talking about transitions. Perhaps we're really at a transition stage in terms of urban health knowledge and practice. I probably spent about 15 years, describing urban health problems. And about 5 years ago, I said, Trudy, to myself, for goodness sake, I've had enough of this. I want to move on to urban health interventions and evaluating interventions. But it strikes me we still have to keep describing the problem, because it's not a disease du jour. It's not a disease of the day. We have to keep on describing the problem to various partners who are just coming on the scene. So we have to keep two balls in the air. We have to keep on describing the problems, which some of us are a bit sick of doing, actually. I mean, I kind of think, oh, for goodness sake, people are sick of hearing me going on about, the nature of the urban health problem. But we need to keep doing that. We need to keep shouting it from the rooftops, actually, to enable some people to hear. But we also need, I think, more investment on, what works, and not just these small pilot projects, very, descriptive, but actually turning, as I say, those pilot projects into what I call policy. Well, I call them policy briefs, but different audiences will call them different things.
We have a question in the back.
What about this problem of the small cities?
Well, I think the small cities. I think there's already some cross-learning going on between small cities that could be enhanced not by any health actor, but by urban governance actors, outside facilitators who are working on urban governance programs of the kind that the Comparative Urban Studies program here is very knowledgeable about and writes about quite a lot. So I think the entry point is not health. It's to enable capacity to grow at the local city level through partnerships with those small cities, with other small cities, but with other partners in the country as well, facilitated by, if you want, an urban governance lens, not a health lens. And again, you know, I think the entry point, we're so often as health people or as a health person, we're using the wrong entry point. Often it's not useful to use health as an entry point. It's often useful to use poverty as an entry point or governance as an entry point. So that's what I would say.
But when we do programming, when USA does programming, a fair amount of the resources that we have are in the health sector. And the kinds of things that we're talking about with HIV/AIDS, even avian influenza and polio, for example, are going to be anchored to some extent in those smaller cities. So that kind of wraparound possibility would seem to me we could explore to broaden those areas out. Laboratory support, some epidemiological surveillance activities, censuses, mapping, things like that. You may be able to link it up to try to get at some of the urban issues in the smaller cities.
I'm Edgar Thornton. I'm with the Urban Programs Office. My colleague John took some of my thunder in terms of talking about some of the interesting programs that we're talking about doing in collaboration between Global Health and with the urban team. But these are all issues that are very important to us. I thank the speakers for addressing these issues because these are these are very timely issues. The urban agenda is not going away. As Victor talked about, the train has left the station. It really has in many ways because we're not going to be able to encourage people to go back to the countryside. They are going to continue to come to the urban areas looking for opportunities because, as Trudy said, cities are the engines of economic growth. You know, one of the areas that we're very interested in is looking at the connection with poverty reduction, because I was very interested in Trudy's comments about that, and you know, I'd like to know, Trudy, if there are one or two examples that you might have in terms of linkages that donors have been able to make between poverty reduction and urban issues, because I was just in India, in fact, working with the Spark program and going over that slum, Victor, that you mentioned, which is the world's largest slum, and where do you begin? How do we address these issues to try to work with groups like Spark, who are doing excellent work with slum upgrading? But how do you get to the other various issues that we've talked about here, of the connections with the rural area? Why are people leaving? The issue that our colleague over here from Africa mentioned in terms of the connection with HIV/AIDS and gender equity. These are all issues that relate back to the poverty example. And I'd like to know a little bit more of both of your thoughts on the poverty side. How do we still provide basic services but still get back to the root of the nature of the problem?
Because India keeps coming up as an example, I'm going to refer back to some experiences of mine in India. Again, it's back in the 1980s, but to me it was some of the most promising intersectoral action, if you want, which started with poverty reduction. And these were those of you who know India may smile at this, but it was the old-fashioned slum improvement projects of the 1980s in India, which were in Hyderabad, Indore, Calcutta, Visakhapatnam, for example. And really they were municipal-led, so there wasn't much involvement of either the private sector or NGOs. I'm not necessarily saying that's a good thing, I'm just describing what they were. But essentially they were municipal-led and working with targeting the most vulnerable areas of the city, and essentially providing skills for employment opportunities was the first entry point, but there were also at the same time environmental health improvements, very much focusing on water and sanitation, provision of secure tenure, education, particularly for adult women, health service provision, and what was in the good old days called community development, which was, a broad, I suppose we'd call it social development these days. But they truly were intersectoral projects, but the entry point, if you want, was increasing employment prospects. I think they were fairly successful projects, apart from the security of tenure, because the tenure was given to the males in the households, and often what occurred was, the big criticism of these projects was gentrification. What happened was there was an improvement in the area, very much upgraded slums, but then people in desperation would sell on their patas, their security of tenure, in order to get cash, and they'd move to another poor area. So the gentrification of this sort of in situ slum upgrading was a problem. But in my mind, I would still go back to those if I was pushed for an example of holistic, multi-sectoral urban poverty reduction, which included health from the outset. I would quote those as an example.
Did you want to add?
Can I add something?
Sure.
We all accept the idea that the urban area is the engine for economic activity in most places. But a recent study sponsored by FAO, FAO has a group called the Roles of Agriculture, which studies the role of agriculture in development. And in the case of Ghana, the study found that migration from rural to urban areas is not being because of looking for economic opportunities, but because the people are running away from poor environmental conditions in the rural areas, including domestic conditions.
This relates back to this lady's comment, I think. And I think we have to remember that there are push and pull factors in rural to urban migration. And these are quite well studied. And I think my argument would be it's very hard to reduce the pull factors. But it is possible, as this lady was saying earlier, to reduce the push factors, and we need to work on that at the same time. So I think whenever we talk about rural to urban migration, we have to think about the different drivers of migration, and there are push and pull factors. I'm not saying it's either or, there's often a mixture, but I think they are very different stimuli. And, there's no example of reversing the trend, apart from Pol Pot in Cambodia, of reversing the trend towards urbanization of the rural to urban flow. So I'm a pessimist when it comes to reducing the pull factor, but I tend to be an optimist in terms of what this person was saying in terms of reducing the push factor.
The other issue that's happened in recent years is conflict, where that has caused a lot of in-migration to the urban areas. Places like Addis Ababa and Rwanda as well. We've seen a lot of people migrating in because of insecurity in the rural areas, and that's part of the pull push, if you will. But that's a hard thing to get at as well.
Just to add some examples to the pull factor that it can exist. When I was in Romania, I worked with some mountain villagers resisting a badly developed gold mine, and one of the leaders of the local NGO there was an engineer who left the city to find a healthier, happier, more wholesome life in the rural areas and protect the cultural rights and the human rights and the environmental rights of the villagers. And another example were several young people who also gave up their lives in the cities to help that cause. One woman who came from Switzerland to work there, living there in the mountain village for 4 years. She worked for The Ecologist previous to that as an editor. And also in India, a lot of my colleagues who were JDs and master's level policy analysts at a farmers' rights organization, they too had dreams of going back to their villages and protecting their way of life there. And there is potential, I think, and even the U.S. here, the voluntary simplicity movement, where people have been reducing their work hours because they see a need to reduce consumption and generate other avenues of happiness, such as community, family, arts, creative pursuits, volunteer time, spiritual growth. And there was a study in South America, I don't remember who, but they also gave a list of what generates happiness, and they included those factors as opposed to just that monetary pursuits are not the sole factor of happiness. So, I mean, I really think it's a cultural change, and if you look at the chronic diseases as well, their depression, 20% rate I've heard in the U.S., according to the American Psychological Association. And health factors, pre-processed foods. Why do we have so many processed foods? A reduction in small farms. So if you look at India's efforts, the group that I worked with on farmers' rights, their belief was that if you preserve indigenous knowledge, you're preserving organic farming systems, you're preserving small farms, that in turn will provide for the variety in food and diet to preserve the health of the people, as well as the autonomy of the people, keeping them in rural areas and not flooding urban areas. And so they have a great new law, the Plant Farmers Variety Rights Act, that protected the farmers' rights to save and exchange seeds in counter to a lot of the agribusiness multinational companies that were creating Terminator technology, fruits that would not bear seeds, that would cause the farmers to continually go back to these companies to buy seeds, and then introducing them into a poverty cycle where they would have to give up farming and flee to the cities. So, there's a lot of issues, that we need to bring into the public health argument as well, which include environmental reasoning, environmental issues, and planning and urban development and political science issues as well, and where the concentration of wealth and power is and how to balance that out.
And did you have a question in the back? Yeah, over there. Mm-hmm.
Sorry. Dave Leibson, I'm retired from AID. Going back to a couple points, sort of comment on a couple points, the whole decentralization question, and I think you're correct in pointing to the wraparound, the integration. It seems to me that therein lies, both for those of us that kind of work on the urban management side and those of us that work on the urban health side, it seems to me it has to do with how to help local governments, local organizations, whatever they are, learn how to manage at scale. That the differentiation between a project and a program, that it isn't how to deliver particular vaccines or particular specific improvements, but rather how that organization, be it private, be it local, be it government, what can they do to change things at scale in whatever geography they're working? What are the changes in their processes? What are the changes in their delivery systems? What are the changes in their policies? What are the changes in their how they finance and fund what they do? What are the changes in their training and education of both the people on their staff and the people they're working with? All of those, how to work with management for achieving things at scale is what it seems to me we, the outsiders, if you will, need to be working on. That we will never accomplish it just by delivering this product or this particular project.
And that has the attraction of being relevant to all sectors as well.
Exactly, and the interrelation. That is, thank you for an important point. That it's all the more important that the people working on the health side and the urban management side work together, because they both can scratch each other's backs, if you will. That how you improve urban management. Well, working with a particular health program or health problem is a terrific practicum, and conversely, that the health folk helping a community or a local government manage its way through a particular health problem conversely helps improve management skills of that organization itself, so that neither one can do it alone and both can help each other.
That's a very good point, and certainly I'm 100% in terms of moving things to scale. What we run into is the dilemma of the development environment, if you will, where in our, at least at USAID, in our careers, regrettably, I guess, development is measured in 5-year clips of time, and it behooves you to show results in those short clips. And the trick is getting to some of the issues that you're talking about, Dave, in terms of the system side and the real scale, and some of the issues that John was talking about that may not show direct results in terms of immunization rates and or diarrheal disease incidence, but the underlying policy, program, systems, things that are required in the long run to develop. And balancing that, John's a master of it, I've tried, balancing that in the long run is the trick to try to get the things done. And I think sometimes our colleagues in DFID and places like that have an easier time because you can sign off on poverty reduction, which is a longer term approach, and not as constricted in terms of some of the results orientation that at least we need to deal with, not unreasonably, but have to deal with nonetheless.
Well, I want to thank everyone for coming today, and thank you especially to our panelists. I think it was a great discussion. And I'd like to ask everyone to please take an evaluation form on your way out and fill it out for us. And thank you once again.
Yes, I do.
May I suggest that when we come in for a seminar like this, we could get a list posted back to us with our names and addresses. We could want to get in touch with other people.
Sure. That's a great idea. I could arrange that if you do put your name on the sign-in sheet outside. We can take care of that for you.
Because there's some people who've spoken to you, want to get in touch with them.
Sure.
And then you can get in touch. Thank you, sir. Thank you, sir. I'm going to put my name down. Put it down.
That's a good idea.
Might be please. Touching
I love the word.
Unless there's a champion like that, the politics in WHO at the moment are not very amenable to issues.
My fear for always, if we're going to end up becoming something like what's your name again? It was going to be something like rollback malaria, and it would be.
There's still some big people in Angie Matty.
I know her quite well.
Yeah, she's sort of taken over the mantle, as it were, in South Africa of the environmental and she's the one that we're working with in Joburg. I chair they have the WHR and Collaborative Centre. They're doing some young farmer in Life is doing stuff on indoor air pollution. He's great. He's super. He's a star.
So I don't think we're not doing enough on
How to get
indoor
housing management for adults.
Right. We always have trying to work on
The one thing you could do,
so much of our work is in the USA, he's working South Africa, HIV, so we're
digress the
more
way
about
some
that
of your
It wasn't time to mention a lot of stuff today, but I was going to mention that as a gap. I think, you know, the environmental health HIV/AIDS link. Who's working on that? Yeah, that's a real gap.
HIV/AIDS has a lot of
Joburg would be great because they've got their new development strategy just been launched. I mean, often these are just empty words, but it is in this case in Joburg, and it would be a great city to do something about that.
the situations
Yeah, it's. I mean, unfortunately, they're going to reorganise Joburg City yet again back to the bigger division. You know,
Oh my goodness.
but they've got some.
Yeah.
these tools show a little bit of bipolar, it was responsible for warming substations.